New episode of 1,000-Pound Sisters. Trying to get real in my house, we're getting wild. Got a 7-month-old baby, 1,000 pound, maybe a glass of red wine, I don't know. Be a little wild. I forgot to tell you this yesterday. This is like, I'm not BS on this one, this was a real study. Has anybody heard about the connection with lead and serial killers? So they used to use lead paint, right? If you don't know this, gases or in automobiles used to be leaded gas, and then they converted to unleaded gas. So there's a study, a lot of people don't buy into it, but there is a lot of people that do buy into it, is that the rise of serial killers in the 60s, 70s, and 80s was due to all the lead. It's causing all those neuropsychological issues. Is that when we went to unleaded gas, unleaded paint, that was when we started seeing serial killers start going down in numbers, like in the 90s and 2000s. It's interesting. Not really relevant to sports. May not be on the test. Since Bundy's an answer, I promise you pick it. Or Jeffrey Dahmer's an answer, pick it. Otherwise, don't need to worry about it. So hemochromatosis. This is an interesting one. I think it's because it has a lot of clinical manifestations that you can see. And when you do see somebody with it, you're not going to confuse it with anything else. Like, it's very distinct. My neighbor had it growing up. I didn't know it. I thought he was just an old guy who really liked to tan. Like, I thought he went to like tanning beds. And then when I was in PA school, I kind of put it together and I called my mom and I was like, hey, does so-and-so have this? And she's like, yeah, you didn't know that? Like, no, I just thought he tanned all the time. She's like, you're an idiot. He was 80 years old. Why would he be doing that? So, all right, hemochromatosis, right? Pretty straightforward. It is a disorder of iron metabolism characterized by excessive iron absorption. So you can have primary or secondary, right? Primary being some inherited form of it that's causing for that excessive iron absorption, or secondary, which is usually due to some type of chronic illness. So chronic transfusions, if they're have some type of bleeding disorder, chronic liver disease, or alcoholic or cirrhosis or hepatitis, or chronic hemolytic anemia, which we're going to talk more about in our normocytic anemia. So in primary, the pathophysiology is decreased hepcidin levels. What do we remember about hepcidin? What does that do? That's the regulator of iron, right? So they're inversely related. If hepcidin goes up, iron goes down. If hepcidin goes down, iron goes up. So in this case, it has this mutation on the HFE gene, which is not allowing hepcidin levels to increase. So they're chronically down, which means there's always going to be excess of iron, which then leads to progressive iron overload. What's something else that can impact hepcidin? Would I say, remember inflammation, cytokines, right? That can also impact those levels. And then why we really care is it starts depositing in the organs, leads to organ dysfunction, and if it's not treated, in a lot of like undeveloped nations that don't have these therapies, you'll see organ damage, and then organ failure. So again, very distinct, but what I want you to remember is typically you're not going to see these clinical manifestations till they're over 40 in males and after menopause in women. So you can sometimes see it a little bit earlier than that, but typically this is in older patients, middle age or older. So they're going to have fatigue, weakness, specifically arthralgia in their small joints, knuckles is kind of a finding. What else could we think that is if we saw those hands, not the bronze skin, but just those fingers? Rheumatoid arthritis, right? There's a number of things that can cause that, but distinctly is that skin. So then when we talk about that organ damage, if it's not being treated and managed, you start going into liver failure, and they may have underlying liver disease, so this just progresses that, worsens it. Heart, they start getting cardiomyopathy, that heart's getting bigger, arrhythmias, failures. Pancreas, sometimes you'll hear it called bronze diabetes, they have that bronze skin and they're diabetic, because that iron is depositing on the pancreas and affecting the B cells. Then that skin is that real distinct finding that you're going to see, right? Can't be confused with my mother-in-law who's an Italian from Long Island who used to put baby oil on her skin in the summers to tan. Started getting all these skin cancers, she still won't wear sunblock, so she just has a Mohs procedure done like every 6 months now. That's the way she wants to live her life. But again, it can affect any of these organs. There's some other organs, but these are the most common ones that we talk about. Iron studies, right? So what's ferritin? What is that measuring?
Free iron.
Yeah, so that's measuring iron in the cells, right? Which is what more accurate test for when we're looking at iron deficiency or iron overload. Transferrin saturation, what's transferrin? Yeah, it transfers. That's the protein that iron attaches to and it goes around the bloodstream. So that's going to be increased. Serum iron levels, free-floating iron in the blood. And then TIBC, right? Typically with TIBC, if there's too much iron, measuring that binding capacity. So it's saying there's not any more capacity to measure because iron is high right now. If you have low iron, TIBC is usually going to be increased. And then you're going to do that genetic testing to see if it's primary or secondary. That's if we're confirming we've already made the diagnosis. Now we're trying to see, is it primary or secondary cause? We used to do a lot more liver biopsies to determine these. People don't like biopsies as a procedure. MRIs are becoming more and more common and more of the standard of care, but biopsies you're still going to see. MRIs are important for our chronic follow-up and evaluate our patient as we go to make sure they're not getting any end-organ damage. And here's how you make your diagnosis. So those clinical symptoms suggestive way, what are some of those clinical symptoms that we just talked about? Bronze skin, right? Signs of end-organ damage or end-organ or organ dysfunction. Those knuckles, right? And then that ferritin is going to be increased. So that is a lab number you're going to need to know for an exam, right? Greater than 300 for men, greater than 200 for women. Transferrin saturation. And then that gene mutation is confirmation if it's primary. So if it's secondary, you'll order that test, and if it's negative, doesn't mean they don't have homeocrotosis, or that it just means hemochromatosis, sorry, early in the morning. It just means it's secondary, not primary. So primary treatments, first line is phlebotomy, especially for primary. But if you think about your patient, why they wouldn't be able to tolerate that, if they're already in organ damage, they have chronic liver disease, chronic kidney disease, they may not tolerate going to the doctor once a week to get 500 mL of blood. So this is one of those few disorders where bloodletting, back in the day, Revolutionary War, that we still do. You're going to monitor their labs. Especially in the initial period, you're going to be a lot tighter with these. As time goes on, you can space it out if they are being well managed. For secondary, or patients who can't tolerate phlebotomy for the primary, we're going to use one of these iron chelation therapies. Remember, DEFER is what I'm looking for. That's all I want you to remember for this. Because reality is you're never going to order these meds. You're never going to initiate these meds in primary care. What you may do is inherit a patient and you're going to continue those meds. But typically primary care is never ordering these meds initially. It's going to be done by a hematologist, and then they'll get discharged from hematology with instructions to follow with primary care with lab instructions and medication refills. Essentially all those meds do is it binds to the iron and allows you to move it by urine or feces. There's a lab monitoring after you've initiated treatment, stabilize the patients. And then during phlebotomy, we're going to make sure we get hemoglobin levels, right? Typically, we'll just do a CBC post to make sure they didn't take too much blood. Periodic liver imaging, cirrhotic patients, to make sure that we're not having any end-organ damage or that it's not worsening the organ. Excellent prognosis, especially in developed nations, if they have access to these therapies. Not so good if they already have advanced disease when you find it, or if they're a drinker, or they have cirrhosis, or hepatitis. There's a nice little chart that compares. This is pretty helpful for testing purposes. Break it down so you can find what's different between these. All right, any questions about microcytic anemias? All right, we're going to roll into macrocytic now. This is going to be our vitamin B12 and our folate deficiency anemias, right? And then you're going to see some also the combined and then drug-induced. The definition, the MCV, what's MCV? Size of the red blood cell, right? So what was microcytic levels? Less than 80. Normocytic would be, right? And of course, macrocytic is greater than 100. So it's characterized by these large immature RBCs or macrocytes. And then we break it down into either megaloblastic or non-megaloblastic. Megaloblastic is indicating megaloblast, right? So whenever you hear blast, hematology oncology, what is that telling you? It's an immature cell, but is it functional or non-functional? The blast typically indicates there is an immature non-functional cell. So in this case, with vitamin B12 and folate deficiency, it's impaired DNA synthesis. It's an essential building block for DNA synthesis. So the rest of the cell continues to grow, but the nucleus lags behind, and it's not growing. So when it is pushed out the bone marrow, it's a non-functioning cell. It's large, immature, and it doesn't do anything. Then non-megaloblastic, this is DNA synthesis is not impacted, but the rest of the cell may be impacted. So typically, there's multiple etiologies, but the cell continues to grow, but it's not growing efficiently or maybe in proportion to that nucleus. And the chronic, the one we always think about is alcohol use and drugs inducing that. But you think about liver disease, right? So alcohol use will impact liver disease, or if they have some underlying hepatitis or cirrhosis, can impact it. And there's another flow sheet if you like those. This I'm not going to test on you or test you on, but you can understand it's kind of a generic chart. It's not specific for any one type of macrocytic. So some of those things are not applicable to the non-megaloblastic, and some of those are not applicable to the megaloblastic anemia. But it's just an idea of what some of the things you can see associated with these. Again, so come down that pipeline, we figure out, hey, hemoglobin hematocrit's low. Then we look at the NCV, we determine if it's microcytic, normocytic, or macrocytic. Then if we go down the macrocytic, kind of two different pipelines we can go down. Common being common, vitamin B12 and folate. So those are typically, if I have those cases, after I've got that CBC, I get my smear, my blood smear, look at that, and then I'll start doing a vitamin B12 folate workup, get a good history, and then go from there. And if it's negative on the vitamin B12 and folate deficiency and my history is not specific, then I'm going to start chasing these non-megaloblastic to make sure it's not one of these. Again, it's causing impaired DNA synthesis, so that cell's large, but the nucleus is lagging behind because the DNA is not being created accurately or correctly. And the two main causes that we have are going to be vitamin B12, cobalamin, right? So if you see cobalamin on test, we're talking about vitamin B12. Or folate, which is vitamin B9. So it may not say vitamin B12 or folate, it may say vitamin B9 and vitamin B12, right? The pants, they like to screw with you like that sometimes. The big differentiation between these two are the symptoms, the signs that you're going to see. So typically with vitamin B12, you're going to start getting these neurological symptoms. Paresthesia, ataxia, cognitive decline. The paresthesia is usually bilaterally, the arm, the legs before the arms. So you may miss that if you have a patient, typically if a patient comes in, young, healthy individual with no other risk factors, and they say, I have numbness in my feet, what's the first thing we all think about?
Diabetes.
What's that?
Diabetes.
So a young, healthy, otherwise. I mean, being common in the military, we do stupid stuff, right? We run, we jump, we do all that. Air Force, you guys sit around a lot. I don't know, that's not good for your back. But, so you sit around, and the high on my differential diagnosis, and a 22-year-old is not going to be some diet issue. It's going to be more likely that they have a nerve impingement, right? But you could throw this on your differential diagnosis as being a potential cause. And then folate deficiency, what do we always think about that? We always think of pregnant women, right? They're not taking their folate, their prenatal vitamins, eating those greens, and they get those neural tube defects in their fetus. Vitamin B12 deficiency, there's our primary found in animal products, right? So who would be the patient for this? This is like a strict vegan, vegetarian for years and years, right? So this isn't one of those disorders that pops up overnight. It takes years to develop. But essentially what it is they ingest the food, right? Hydrochloric acid in the stomach stimulates the release of pepsin. Pepsin in turn separates vitamin B12 from the food. And then the gastric parietal cells release intrinsic factor, IF, right? That's what the vitamin B12 binds to. And then that allows to be absorbed in the terminal ileum, right? So anything that's impacting their IF, so what are some things that can impact the release of pepsin in their stomach? Talked about it yesterday. What are some meds? DPI, what else?
Pepto?
Yeah, Pepto would be like chronic if they're taking Pepto every day. Some H2 blockers maybe, right? Somebody who's taking chronically antacids, so it may not be prescribed, it may be over the counter. Or a nervous person, so they take a lot of antacids. Other things that can impact their absorption, right? If they have an H. pylori infection that's not being treated or they don't know they have, or anything that's being done, they've had surgeries or some type of autoimmune disorder that affects their intestines. What I want you to get out of this key role, all I need you to know is that it's essential for DNA synthesis, right? It's impacting DNA synthesis. The other stuff is good to know. I'm not going to test you on it. PANCE isn't going to test you on it. But you need to know that this is megaloblastic anemia, so it's vitamin B12 and folate, and it's impacting DNA synthesis, which is causing these large, immature, ineffective, non-functional cells to be released that have poor nucleus and a large body. Why it takes years to develop, significant stores of vitamin B12 are primarily in the liver, right? So this person may have been a strict vegan for like 2 or 3 years, and then they have some underlying injury or disease patterns in the liver that may be the kind of precursor that goes, or they had no injury or illness to their liver, and now they're just starting to show symptoms, and those symptoms initially may be vague. About 25% of those are going to have those neurological symptoms that we talked about. Here's some of the causes for that, right? So if you can, you don't necessarily have to memorize this list, but if you understand things that could just by common sense, right? What's atrophic gastritis? You guys learn about that in GI?
Gastric muscles stop working, they atrophy.
No, so what's itis?
Inflammation.
Inflammation, right? So this is a chronic inflammation of the stomach lining. It's going to impact those cells' ability to release pepsin, right? And so it's also what's the most common cause of atrophic gastritis right now? Having H. pylori infection, right? So just typically we think H. pylori with what? Peptic ulcer, GERD, right? Somebody comes in with GERD, we initiate them on PPI, doesn't get better after 30 days, then we chase down the H. pylori infection. Not all patients with H. pylori infection are going to be symptomatic. So again, if you have these vitamin B12 or folate deficiencies, and patient isn't complaining of GERD, you still may want to work it up if you're further along in the workup and there's no explanation of why, because we want to figure out that underlying disorder. Crohn's disease, celiac, short bowel, anything that's affecting their ability to absorb, right? Post-gastrectomy, taking about 1,000-pound sisters, right? They got their stomachs cut out because they couldn't put food down. Dietary is rare because it said it takes multiple years. They can take supplements for that too as well. So that's less common finding, a less common cause for this. But again, it's going to be a very strict diet with no supplementation. And it's not going to be something that a fad diet that they've been doing for 6 months. We need to look at those people who have been doing it for years. Alcoholism, right? That definitely impacts the way we absorb nutrients. It also impacts our diet, right? If you've ever seen a chronic alcoholic, they don't eat, they drink their meals. Psychiatric patients, right? You guys already done psych? What's a typical workup for somebody with depressed? It's a lab workup, right? We look at anemia, their thyroid. We also look at vitamin B12. They're increased risk for that. So showing a lot of depressed patients with the diagnosis of depression have low vitamin B12 levels. But you can also see that in the children, right? If their mothers are vegans and they're breastfeeding, they're not getting all those nutrients that they need. They may not take the supplements that the pediatrician recommends. And again, there's prolonged medication uses. Metformin, what do we use metformin for? Diabetes, right? That's probably going to be the most common medication you're going to prescribe for diabetes in primary care. Once they start getting too complicated, we usually punt those off, unless we have the bandwidth and the time to do it. And then PPIs and H2 blockers. So PPIs are increased risk versus H2 blockers. You may see with H2, more likely you're going to see with the PPIs. Initially, those symptoms may be vague or non-specific. Again, what are some common symptoms of anemia? Fatigue, pallor, maybe some shortness of breath. Maybe if it's like a middle-aged man, what we may see too as well, they come in to complain about. ED, or just decreased libido, right? So that guy may have all these, but then when he has that decreased libido or ED, he's like, oh, all right, now I need to see the doctor. Glossitis, right? That beefy red smooth tongue, it can also be a little bit more inflamed and have a little bit of geography on it. Diarrhea related to malabsorptive symptoms, but the big one we think about with vitamin B12 are those neuropsychiatric, right? It's symmetric paresthesia, or numbness, legs typically more than arms, gait difficulties, progressive weakness, ataxia. What else could we think about when we see these symptoms? I'll be honest, I started thinking about like MS, Parkinson's, ALS. I was raised with a lot of Catholic guilt, so I automatically think the worst and everything. I start going towards like the horrible things that it could be. So if I see these symptoms, I may not think initially this is just a vitamin B12 deficiency. I may think it's something else, and I may start doing a deeper dive and doing MRIs and start sending consults in when it's not necessarily needed this time. And they may just have those vague personality, depressed mood, right? They just maybe, hey, I just feel low energy, I'm a little down. If you're like in Alaska or Fort Drum, New York, where it's snowy and cold all the time, you maybe, hey, maybe you just need some sunlight therapy or something, right? But you're missing that vitamin B12. I know you guys don't have this picture on your slide, but I threw that in there so you can see some of the stuff. So again, it's macrocytic anemia. Peripheral smear, you're going to see these macro ovalites right here. You see them, they look oval. And then you're going to see those hyper-segmented neutrophils right here. See that? And then vitamin B12 levels, of course, is going to be decreased. And then MMA and homocysteine levels. So this is from protein metabolism. It's determining, we use them for other things too. We use homocysteine in some of our cardiac patients to see if it's heart failure, but they're also indicated in this. So you're going to see those increase. Typically, you're going to start your patient on oral vitamin B12 supplements, 1 milligram daily for 1 to 2 weeks. If patients are going to buy them over the counter, one thing I always tell them is make sure that it's has that USP stamp on there, right? United States Pharmacopoeia. So make sure, at least because in the United States we don't regulate our supplements. Typically, if you prescribe it, it's going to be coming from a source that is known to be good. You can think about injections if they are not improving with the oral supplements, right? They sell B12 injections. That was a big fad a few years ago for increased energy. Typically not required if they are tolerating the supplements and they are being compliant with that medication. But we also want to look at secondary causes, treating the underlying diseases. If they're on chronic PPI, maybe do a break off of that and see if they can tolerate it. You're going to consult, like GI may say, hey, this patient needs to be on chronic PPI. You can consult back to GI and say, hey, now he's starting to get vitamin B12 deficiency, he's not tolerating the meds. Is there anything else we could put them on, or could we do a break off this and partner up with them? And then lifelong therapy for irreversible causes, pernicious anemia, which we'll talk about here in a second. The big thing is if we don't aggressive with this and identify it early, some of these neurological symptoms can be permanent and long term. I would say it's less common, but it is possible, so you want to be aggressive with these and start working them up very quickly if they come in with these symptoms. Pernicious anemia, very similar to vitamin B12 deficiency, but in this case, It's an autoimmune disorder that is destroying those cells and releasing inability to decrease the IF, right? So this is an autoimmune disorder. It's going to present very similar to vitamin B12 deficiency, but typically the neurological symptoms are going to be more aggressive. They're going to be more pronounced. You're going to have the same lab values that you did for vitamin B12 deficiency, but what you're going to see is these autoantibodies to intrinsic factor or parietal cells. That's going to be the key test. That's probably not going to just pop up when you look up labs, so you may need to call the lab and say, hey, I need to order a kind of random lab. Do you have this available? If they don't, they'll typically send it out for you, or they'll send the patient to another lab off post. They don't have it available. But these patients, in comparison to vitamin B12 deficiency, we typically are going to be doing injections for them versus the oral. Oral typically is not efficient and effective enough in these, so we do straight to injections. Some places, they'll have to come in weekly to the clinic to get these. Other places, depending on how it's set up, you can deliver it to them and you get patient education, nursing gets involved, and they teach them how to do the injections. Why would we test for this? Is if they're not responding to the oral supplements, or there is no obvious cause for that B12 deficiency, that would be when we test for those autoantibodies. But if they're responding to treatment, typically the RBCs are going to start normalizing 1 to 2 days. Those hyper-segmented neutrophils will disappear in 1 to 2 weeks. And then neurological signs and symptoms are reversible of less than 6 months. Greater than 6 months, the likelihood of them being long-term increases. All right, so the other one that pairs up well with vitamin B12 is going to be our folate deficiency. So leafy green vegetables, fruits, legumes, fortified grains. Anybody here from the South? Right? What do we eat in the South that's popular? It's like this. Collard greens, right?
Yeah.
How do they make collard greens? Boil the hell out of it, right? Steam it. So if you steam it, it's actually better, right? So prolonged cooking, especially boiling, is going to leach out that folate from it, so you lose about 50% of it when you do it that way. But back in the day, anybody heard of the liquor fluid or liquor water? That's that fluid that's left in when you cook collard greens. So back in the day, slaves in the 1800s, 1700s in the South would drink that fluid, would keep it and make it for a base for the rest of their food, or use it for other things because it was so nutrient heavy, right? So when you boil it, when you eat the collard greens, the fluid gets left behind. That's where a lot of that fluid is, that nutrients, right? So I identified this in one of my patients at Fort Hood. It was a kid who lived in the barracks, and he ate nothing but chicken. He had a George Foreman grill, because what do young guys think when they're trying to get big and muscular? What do they need?
More protein.
They need protein, right? So all he literally did, his roommate was a medic, and the medic was like, he's weird as shit, sir. He just eats chicken. That's literally all he ever eats. He just does a George Foreman. In the morning, he puts 2 pieces on. At lunch, he does 2 pieces. At dinner, he does like 2 pieces. That's all he ate. So he was never getting any vegetables. And then what was he taking on top of that chicken? Scoops of protein, right? About the only other thing he had in his diet was beer on the weekends. So he got big, but then he had like no energy. So he was just like Igor on Winnie the Pooh, just like, hey sir, just always down. He had a little power to him. So I got into him with about his diet and found out he wasn't eating any vegetables at all, really. We identified it and diagnosed him with folate deficiency. So absorption is in the small intestines. You need these brush border enzymes to convert it to polyglutamate, and then that's how it's actually absorbed in there. So if there's something going on with that, that's probably like a 10-step workup to look for the brush border enzymes that I would never do, that hematology may do. But so you know the absorption and how it happens. Again, DNA synthesis. So it's back to nucleotide synthesis, cell division and growth. So if it affects DNA synthesis, what's that cell going to look like? It's going to be big, and it's not going to have a nucleus, or a non-functioning nucleus, or a small nucleus, because it's not getting the appropriate building blocks. This, though, smaller source compared to vitamin B12, primarily in the liver, so this can actually develop in 2 to 3 months. So if a patient comes in and they're doing like a fad diet that they saw on social media or somebody told them, then they're going to talk about this is going to be a lot more aggressive and a lot quicker in these symptoms, so 2 to 3 months. But the big characteristic of this versus vitamin B12 is you typically do not see those neuropsychiatric symptoms associated with this. So you're going to have more along the lines of those vague anemia symptoms. But inadequate folate intake, right? Restrictive diets, that guy who's just eating protein, or younger patients that may have eating disorders, right? Elderly alcoholics, you'll see a lot of folate and B12 deficiency in alcoholics. Anything in the GI disease, Crohn's disorder, right? And then every pregnant woman should get what?
Folate.
Prenatal vitamin with folate in it, right? It's pretty much standard of care. Typically, when a pregnant woman comes into primary care, unless you're in like some very isolated clinic without anything off post, because some of the Air Force bases are in very isolated areas like Missouri or North Dakota, South Dakota, right? If there's not a great hospital there or on the outside community, you may be doing a little bit more, but typically for pregnant women, especially in the Army, give them the pregnancy test is positive, write their profile, give them prenatal vitamins, and consult the OBGYN. Typically, your hands off after that point. Make sure every one of them is getting that. Drugs that can affect it, alcohol again, PPIs, H2 blockers, any of that stuff, or contraceptives to a lesser degree. I haven't seen a big correlation with that, but there may be some studies that support it. No, you don't have that picture, but there's another example of that glossitis, that big leafy tongue, right? Maybe more erythemus, but it's light losing papillae on the tongue. It's nice and smooth. And again, they have those generic, vague signs and symptoms of anemia. But I have a strong indication for somebody who's markedly decreased their dietary intake. They're trying to lose weight, right? So this is one of those cases where they send you a soldier or an airman or sailor, marine, whoever that's overweight. Why we send them to nutrition clinics so they can actually do it correctly instead of doing these crash diets where they just stop eating and they're only drinking water. Or anybody watch The Office? She's doing that fasting diet with like cayenne pepper, lemon juice, maple syrup, and she looks all run down. So make sure they're not doing fad diet, because that's going to be kind of a red flag if they're doing some crash diet to lose weight for a wedding or a PT test or something. And then increase in alcohol abuse. Again, going to look very similar to our vitamin B12. We're going to have decreased folate levels. But in this case, MMA is going to be normal for this one. That's a distinction back between that and vitamin B12. So if you have a test question and it gives you all these labs, but it doesn't give you vitamin B12 or folate, that may be the distinguishing factor, is that MMA is normal versus the other one. And again, pretty straightforward. The management, you're going to give them folic acid. Unlike vitamin B12 or iron, this is usually well tolerated, so is vitamin B12. But if they're not having those neuropsychological symptoms yet, right, doesn't mean they don't have vitamin B12 if you didn't test for it. But if you start treating with folic acid, you may start seeing improvement of their labs, and then they develop neurological symptoms. That may indicate that, hey, you're treating the folate deficiency, but you're not treating vitamin B12. So that may be an indication they need further workup or further treatment. And then combined, this is very straightforward, right? It's what we just talked about. Now you're combining it together. They're going to have decreased folate, decreased vitamin B12, not B12. And in this case, they're going to have that increase in MMA because vitamin B12 deficiency is included in this. And you're now going to just treat them with B12 and folate. All right, so now we're going to go to our non-megaloblastic anemias. So again, real world, you get a patient, you get that CBC on them because they come in with these vague, nondescript symptoms. They're fatigued, pallor, they just don't have a lot of energy, maybe decreased libido, they're just getting overwhelmed with stuff. Get that CBC and we determine it's either going to be, their anemic, it's going to be microcytic, normocytic, or macrocytic. Then we kind of go down those pipelines. If it's microcytic, I'm thinking what? What's the first thing I'm thinking? IDA, or iron deficiency anemia, right? It's the most common anemia, it's the most common microcytic. Now we're in that macrocytic. I'm thinking the first thing I'm thinking is going to be vitamin B12 or folate deficiency. So I'm going to kind of do that workup If that comes back normal, and their history is not specific for anything, they don't have any medications that are big red flags that are any like PPIs, and they don't have a history of alcohol, their diet's pretty good, then I'm gonna start going down this pipeline on the right of non-megaloblastic anemias and start working these up. So these are large cells, and it's not impacting the DNA synthesis. Doesn't mean they're not functioning correctly or incorrectly. It just means the DNA synthesis, that nucleus is fine for the most part. It's going to be the cell is large and not functioning correctly. And there's a number of etiologies, so I'm not going to go in depth, but it's other than impaired DNA synthesis for these non-megaloblastic anemias. Again, so if you go down that pipeline, you test vitamin B12 and folate, and those are all normal, then we're going to start taking non-megaloblastic. Alcohol abuse is number one. All right. Some of these kind of surprise you. Emphysema, COPD. Right? They have chronic inflammation. They're on meds. They're always sick. They're coughing. They get. What are COPD patients at risk of? What's a key characteristic of COPD?
Smoking.
Frequent infections. Right? They are susceptible to infections. So that, and then if they're chronically hypoxemic, what's that telling the body to do? What does it tell the kidneys to do? Yeah, increase EPO, right? So increased EPO is not always efficient if you don't have the building blocks, but it can also put stress on the bone marrow, which can cause some of these macrocytic. It's an increased stress, so it's trying to push out RBCs sooner than later, so you get all these large, immature red blood cells that are not functioning correctly. Hypothyroidism, accelerated erythropoiesis, right? What I just talked about. Hepatic disease, right? Because can the liver make EPO? It's primarily the kidneys, but the liver prenatal is the primary function making EPO. And as an adult, your kidneys aren't functioning correctly, your liver can make up some of that and do about 10% of the work to make EPO. So if you have liver disease, that can also do it. Bone marrow failure, aplastic anemia, MDS, or some other causes. So, all these medications, two I would want you to focus on is anticonvulsants and chemotherapy agents, right? So, not necessarily what they individual are, but if you have like a vignette or a question that says, hey, this patient recently was treated by neurology for seizures, that may be cluing you in that they're on a medication that is causing this non-megaloblastic anemia, right? Or, hey, the patient is in just underwent chemotherapy for some type of cancer. Now they're following up with you and they have anemia. That may be cluing you in that they completed chemotherapy. So think about that. These are all medications that. Allopurinol, what do we prescribe that for?
Gout.
Gout, right? Do we see a lot of gout? Yeah, it's coming back up, man. Right? The America's fat. San Antonio is the home of the obese meth addicts. Antacids, we prescribe a lot of these in primary care. Antibiotics, oral contraceptives, metformin we talked about. And some of the other ones that are a little less common. So it varies depending on the underlying clinical case, right? So if alcohol is going to present significantly different than somebody that's just taking a medication or a diabetic that's taking metformin for long periods. In this case, macrocytic anemia, which we've already talked about, which is MCV of what? Greater than 100, right? And in this case, we've already done our vitamin B12 and folate levels that are normal. So in this case, we have to start hunting out these zebras and start figuring out whether it's a dedicated history. If the history is unremarkable, look at their medication record, see if any of those trigger red flags. If that, then this is where you start shotgunning some labs and you start working on some other things. It's not clear case. But if you identify those medications, you're going to discontinue or adjust them. This is where you talk to your clinical pharmacist, right? Like, hey, I have a patient on metformin, it's doing great. They've been tolerating it well, but now they're starting to develop a non-megaloblastic anemia. What recommendations do you have for another medication that I can replace this patient with? Right? So utilize those resources. I talk to my pharmacist just about every day. I think he got sick of me, but well, that's what he got paid for. And then here is a summary chart so you can differentiate these type of macrocytic anemias for your tests. All right, any questions? All right, it's going to take like 10 minutes and then we're going to jump into normocytic anemia. We're not going to do all this today. We're going to get down to probably like G6P deficiency, and then we'll call it a day, and you guys can start your next class a little early. Hopefully get you out today or have a longer day. All right, so kind of beat this up, right? MCV, normocytic is going to be 80 to 100. It'll be within normal limits. Common causes, decreased production, right? Chronic disease. I said chronic disease anemia could also be normocytic, but what else? Yeah, it could be microcytic. Aplastic anemia, that's a scary one because that can mimic a cancer. We'll talk more about that. Hemolytic anemia, what's hemolytic mean? That's the, premature destruction of RBCs, right? So your body's indicating there's some reason, whether it's autoimmune or there's a defect in that RBC that it needs to be destroyed, and what it's primarily destroying and where to go. Spleen, so what do you think, what happens to the spleen? Splenomegaly, right? And then acute blood loss, that should be pretty straightforward, right? Somebody gets shot or gets in a wreck and they just start dumping out blood. Is that going to impact your hemoglobin or hematocrit? Initially, probably not when you draw that first lab, and then over time you will. But it's not going to impact the MCV at all, is it? Right? Because there's nothing going on with the RBCs themselves. Anemia of chronic disease used to be called anemia of inflammation. You may still hear that term. It used to be called anemia of inflammation because it was primarily associated with cytokines, but then they started seeing that, hey, it's not necessarily inflammation, it could be infection or these chronic disorders that are also causing this. So, most frequent anemia in hospitalized patients, right? So you have that patient who gets admitted for a number of days and then they get this acute process. From inflammation, or they have a chronic disease that hasn't been managed correctly or very well. They get admitted, you start working them up, you get anemia. I want you to think, unless they already have some diagnosed anemia, I want you to think ACD, right, or anemia of inflammation. Multifactorial, so inhibition of RBC, right, production. So if their kidneys failing them, they're on dialysis, they may not be producing enough EPO, then in that case, the liver may kick in. If the liver has damage, or alcoholic, or they have some type of hepatitis, the liver may not be able to function correctly. But essentially what we're seeing, inflammatory cytokines, right? And then, kind of reiterate, what is hepcidin? What does that job do? The regulator, right? That's what's driving the train for iron to be released from the cells. And then what is actually releasing iron from the cells? That trap door, what is it? All right, you're studying on that. So remember, hepcidin and iron are inversely related. So hepcidin goes up, iron availability goes down. So the cytokines get released from inflammatory, right? That's going to drive the hepcidin up, which is going to decrease your iron availability. We need iron to create these red blood cells. It's an essential tool or essential building block. So it's going to decrease our iron availability for erythropoiesis. What's erythropoiesis? It's the production of RBCs, right? What we also see is when the cytokines get released, it's going to drive our EPO production down, which is EPO is the what? It's the hormone that stimulates the creation of RBCs, right? So, and where is EPO primarily made? Kidneys, but it could also be made in the liver too, right? That's also going to further decrease erythropoiesis, our ability to make red blood cells. And this is just a reiteration of what we just talked about, right? So hepcidin is inhibited by hypoxemia, erythropoietic demand, because they're inversely related. So again, a lot of these patients are going to be asymptomatic, or they have very vague symptoms that all anemia has: fatigue, pallor, and weakness. So in this case, what is most important when we initially evaluate that patient? It's going to be the history, right? includes maybe, and they may be a poor historian that may not be able to provide you reliable history, or their family member may not be able to prescribe. Who here can like accurately right now something about your parents, tell a doctor everything that's going on with your parents? Right? Like I can't. If I did, I'd be like, she had her appendix out when she was 12. That'd be like what I remember, right? So historians may not be great. And you look through the medical record, do a little dive to see what's going on, or the medications they are on. They may not be able to tell you why they're on them, or their family member, but the medications may clue you in that there's some chronic disease underlying of why they're having this. CBC is going to be normocytic, normochromic. How will we know that it's normochromic? What lab is going to give that part of the CBC? Maybe that's MCH, right? Mean corpuscular hemoglobin. So it's hypochromic, that's going to give you that pale appearance on blood smear. On normochromic, it's just going to appear like a normal red blood cell. It's not going to have that pale center on it. Serum iron is going to be low because the hepcidin, CIDC, they don't have enough iron to bind. Or ferritin is going to be normal to high, transferrin. And then this is where you start using those inflammatory markers, CRP, ESR. That's not going to give your diagnosis, but it's supporting your diagnosis that there is some type of inflammatory process that's driving this train that would be causing this type of anemia. The diagnosis of exclusion, you rule out everything else, take a good history, you look at their labs, figure out, okay, there's not really a great explanation for this, they can't find anything else. So, diagnosis of exclusion. Decreased serum iron, normal to high ferritin, decreased transferrin. But the most important thing is you're going to look at those underlying chronic disease or infection and manage that better. Chronic disease could be what? It could be kidney disease, it could be liver disease, it could be some type of autoimmune, it could be some type of pulmonary, it could be a number of illnesses or issues that are causing this. And then erythropoiesis stimulating agents, right? This is that stuff that Lance Armstrong and the other people were using. I actually had a guy at Fort Bragg that was using this. I don't think it's really risky to get better on your APFTs, but he got caught of using this, and the commander didn't even know how to like go about it. Like we were involved with CID, we're like, does this need to be prosecuted? Like, how do we? This isn't typical of using drug. Eventually, how they busted the kid was he was selling it to other people in the barracks, so that's how they ended up getting him. But it was the weirdest like CID case. I got brought in as a medical reviewer, and I was like, I don't know, man. Sure, I guess. Any risk with these medications? Yeah. So it increases risk for heart disease, stroke, because it's basically thickening the blood, right? If it's not managed correctly, you over-prescribe it, then it creates this over-proliferation of blood cells, which is making it hyperviscous, cause issues. So not a benign medication, it does have issues. They're very symptomatic, like in the hospital, and while you're working this up, because you're trying to manage that chronic disease simultaneously, may be indicated for blood transfusions at that time. And then that would be when we have a transfusion class we'll talk about. It may not be whole blood, it may just be packed red blood cells, or it may be different types of blood products. So anemia of chronic kidney disease. When I say anemia of chronic kidney disease, what should be like the first thing you're thinking about that would cause anemia of chronic kidney disease? We talked about it multiple times now. What's that going to impact? The EPO, right? This could be the number one issue that's causing that. So some of these are pretty straightforward. You see anemia of chronic disease, thinking that, what would be some indications of chronic kidney disease? So hypertension could cause chronic kidney disease if they're not being well controlled in their medications, they're not taking them, they're not compliant, it's undiagnosed. Some clues like in the ER, patient comes in the ER, what would be some other clues?
History of AKI.
What's that?
History of AKI.
AKI, all right. Patient was in the dialysis clinic. They started having some issues, right? History of dialysis, history of frequent kidney stones, right? And then what kind of lab values would we expect to see with chronic kidney disease? Okay, GFR, increased BU and creatinine, right? These are the most common that we see. There's some other lab values. So again, primary is that reduced EPO production due to damaged kidneys. This can also drive the train now. If EPO is not produced, it can start putting stress on the liver because the liver will try to compensate, but it can only compensate so much, it'll be about 10%. So if they have this chronic kidney disease and they're chronically anemic, then it's going to put stress on the liver. But iron deficiency due to blood loss from dialysis, impaired absorption. If you're ever interested as a PA job, they have a lot of that is in dialysis clinics. Pay is usually garbage. Patients are not the best, most compliant. They're usually very unhealthy patients with poor lifestyles, but it is a job avenue you can pursue if you want. Reduced RBC lifespan, uremic environment, right? The kidneys are failing, starts becoming more uremic. Bone marrow suppression, again, the uremic toxins are going to affect the bone marrow, so it's not being able to produce. So this is a lot of things going on at once, multifactorial. And then to a lesser degree, less common but possible, is that vitamin B12 folate deficiency that's contributing to this. This is going to have a gradual onset because typically chronic kidney disease is not like one insulting injury or illness. This is going to be over time, right? That hypertension that is uncontrolled, alcoholic, speeding up their kidneys, and you're going to start to see that slow progression of kidney failure where it's not working correctly. And then these symptoms are going to start presenting as that kidney continues to fail. So again, it's normocytic anemia, so it's going to be normocytic, hyperchromic, the MCV and MCH are going to be within normal limits. May draw a reticulocyte count. What are those reticulocytes? Immature RBCs, right? If the reticulocyte count is increased, what is that kind of telling you generally? The bone marrow is working overtime to try to create RBCs to replace something, right? Something's going on underlying. If it's decreased, it's either something driving that train or you're starting to get a bone marrow failure. You can't keep up with production. Serum EPO levels, right? Key diagnostic finding because we're concerned about that. That's what's driving the train with that kidney disease. The kidneys can't keep up with EPO, which means we can't do erythropoiesis, we can't create RBCs. You'd also do additional iron studies. They're not needed for the diagnosis here, but that may be a contributing factor as well. And then importantly, the first clue you may see is that renal function test, right? Draw labs, baseline labs in the ER or primary care clinic, CBC, CMP, UA, all that good stuff. And then this may be the incidental finding right here. A patient may not know. And you start kind of piecing things together and be like, you ever been told you need to take blood pressure medications? They're hovering at 160 over 100 and they've been there for years. Things like that. Has anybody ever talked to you? Have you ever been seen by nephrology for anything? Primary goal, improve symptoms, reduce need for blood transfusions. So how we do that is managing the underlying chronic kidney disease, getting them into nephrology, potentially getting MRI or CT to see if there's some type of physical impairment, tumor on there. If you had a tumor on the kidney, would that go to nephrology?
Urology.
Who would that go to?
Urology.
Urology, most likely, right?
Stop believing.
What's that?
Sensitive.
Yeah, I think so. Honestly, for PA school, I think there should be a class dedicated to who you consult stuff to and who does what in the hospital. When I first began PA, I was just like sending the most random shit. I was sending stuff to general surgeons. They're like, "Are you retarded?" Every once in a while, you would get like a nice consultant on the phone. They're like, "Hey, man, are you new?" Is there a way of telling you you're stupid right now? I'd be like, "Yes, I am." They'd be like, "Hey, man, interesting consult. Doesn't go to me, it goes to this guy. I already forwarded it for you, but in the future, don't send that hot garbage to me." I'm like, "Thank you, sir." So, if you're not sure where stuff to go to consult with one of the senior PAs, brigade surgeon, especially the DOD. Like these are small communities, right? If you go to like Fort Bragg, there's maybe only like one hematologist or one nephrologist. If you're sending them bad, like me, I stand out because Rakowski, right? I'm the Rakowski in the DOD. So like I can't really hide out. If you're Smith, well, then good for you. You can hide out. But that is a problem I'd say with most new PAs. You just don't know where to send stuff. So ask them in advance or pick up the phone and say, "Hey, you know, rheumatology, does this go to you or orthopedics?" Typically they would appreciate that versus you just sending a consult. So again, we talked about the ESAs that may be indicated because we're trying to stimulate the EPO production or replace it with synthetic EPO and has those risks associated with it, right? Stimulates RBC production, but important considerations, you need to monitor those hemoglobin levels. I've had a few of these patients that I inherited on a panel, so I would just call nephrology and be like, hey, how often do I need to do this, or hematology, and say, what's your recommendation for this? And we would do them every 90 days for the patients I had. Other places may have different guidelines or different recommendations, but it does increase the risk of thromboembolic events and hypertension, so you need to manage those and be following those closely because that could worsen their chronic kidney disease. Iron supplementation, right? If they're really far gone, they may not respond to that oral, or they may not tolerate it, so you may need to consider IV. At this point, chronic kidney disease, they're going to be seen by multiple disciplinary teams. Typically, they're going to be under the care of nephrology. Odds are they probably have some heart disease associated with this because they're not managing their life correctly, or they just have poor health. So you're going to have multiple people involved with their care. Sometimes in primary care too, you're going to find the difficulty. This is kind of real medicine, getting away from textbooks and stuff. And you kind of have to be the person that levels everything out, right? If you have somebody going to 4 or 5 different consultants or experts, they all have a different approach to stuff, right? So if you have a patient in the ER, say for example like a DVT, general surgery, hematology, they're going to have different ways of approaching. ER is going to have a different way of approaching it, so they may recommend different things. Sometimes you kind of have to get everybody on the same page. There's been a few times, and it's always interesting when you do this, is you email everybody or you get a group chat going together, and you'll see like 06s just calling each other out and start screaming at each other and being very difficult, but it's sometimes you have to level the bubbles because that pulmonologist doesn't necessarily care about that concern that rheumatology has, or hematology doesn't have that concern that pulmonology has. So sometimes you have to level those bubbles and be the one that brings everybody to the table to get them on board. Blood transfusion, reserved for severe symptomatic anemia in response to other treatments. So again, that's typically going to be indicated, especially in an inpatient setting. If they come to the ER, then that may be an indication. So anemia of chronic liver disease, a little bit more complicated than chronic kidney disease. It has a multifactorial kind of approach to it, and it can affect a lot of things. More complex than chronic kidney disease. Key contributing factors. So what's the difference between hypersplenism and splenomegaly? What's that? So splenomegaly is just a physical exam finding, right? So you're just noting that, hey, it's an enlarged spleen. That could be a physical exam. That could be on MRI, CT, ultrasound. Hypersplenism means the spleen's working overtime, right? It's hyperactive. So it's working, which is going to in turn most likely increase the size of that spleen. So two distinct words, a lot of times they get mixed up. But that splenomegaly is going to lead to increased destruction of RBCs. So bone marrow suppression, right? Alcohol can suppress bone marrow. Uremic environment from the kidneys, viral hepatitis, right? I had a sergeant major when I was at Fort Lewis, came in right after his R&R. He went on R&R and went back to the theater for like a few weeks, and he came back and he was the rear D sergeant major. And he was looking a little jaundiced and just looked like shit, and the guy was very active. Started having that, he got hepatitis in Mexico from street tacos. So, healthy guy, didn't have any risk factors. He wasn't a drug user. He wasn't having unprotected sex with a bunch of random people. But his wife never made him go on a vacation he didn't want to go on again. That's that. So you'll see these weird presentations that may not be the classic, IV drug user, somebody sleeping around and all stuff. Nutritional deficiencies, right? Alcoholics specifically, I think about. They have poor diets. They drink their meals. Can impact this. Again, so reduced EPO production, impaired liver function can affect EPO regulation. So again, like I said, the liver is kind of the backup kidney for EPO production, especially in somebody with that chronic kidney disease that can be affecting them. Increased hepcidin, inflammatory state can lead to iron restriction, right? Talked about that, hepcidin, those cytokines, inflammatory markers, we're going to increase that. They have that chronic liver disease that could be affecting that because their inflammation, having all these issues on medications. Then blood loss from varices or other GI bleeding. So if you have a liver disease, who does that go to in the hospital? What do you think?
Pathologist?
What?
Pathologist?
Yeah, you're going to be hard to find a dedicated hepatology clinic in the DOD or most hospitals. GI, right? When I was in school, I wouldn't have thought, but GI is usually the one that manages liver disease. There's other people in internal medicine will help out, but typically GI is going to be the main person affecting that. If you go to like a big medical center, BAMC may have like GI and then a subclinic underneath it that is dedicated to liver disease. The presentation, right? The generic anemic symptoms that we see in everybody. But this one stands out because now we start getting those typical liver disease, chronic issues, that jaundice, right? They have that yellow skin. What's the sightings?
Fluid in the tissue?
Yeah, free fluid in the abdomen. So I was in Central African Republic, South Sudan, Uganda. I was assigned to, at the time, 20th group. Or was it 19th? What's North Carolina? Is that 19th or 20th? I was assigned to working with 19th group, and we were working at doing like global health engagements at a local clinic. And there was a guy there with chronic liver disease. There was an alcoholic drinking like the local moonshine stuff that they made, and he had really bad ascites. About once a week he would come in there, and it was great training for us, and especially for the SOCMs. We would tap his abdomen once a week to drain the fluid off, because he would come out, we would drain like a liter off, and then he would come back a week later. His family would bring him on this little rickshaw looking thing, like 2 wheels. They would pull him to the jungle. Belly would be big and distended again, and we would drain off some more. Very distinct finding, right? It looks like that guy has a big beer belly, but the rest of his body doesn't match. What's hepatosplenectomy? The large liver and spleen, right? You may see that on ultrasound, you may just see that on physical exams where they're just, you don't even need to measure it, you just see the liver kind of poking out underneath that rib cage, and then the right side has a big, the left side has a big swelling into it as well. This is kind of like anemia of chronic disease. It can have a variable morphology, so it can be normocytic, macrocytic, or microcytic. So it kind of depends on what is that contributing factor to it and when you're catching it. So if it's early on, right, it may be normocytic. If there's some type of iron deficiency associated with this, one of those other ones, it may be microcytic. Macrocytic, if they're an alcoholic and they have a poor diet, you may see that with that B12 folate deficiency. But they're going to have that decreased hemoglobin hematocrit, which is distinct, right? Or not distinct, but common. And that's going to vary depending on the severity of liver disease and when you find it, right? So just remember that CBC, whenever you're looking at a CBC, it's a snapshot in time, right? If I look at an A1C, is an A1C snapshot in time? No, that's more of like an over period, right? Fasting glucose would be that kind of snapshot in time. CBC, it's always a snapshot in time, so you're looking at it right now. So if you can, what do? Look at other CBCs. You don't have other CBCs, what can you do? Draw another CBC, right? And you correlate that and you're looking at it over time. So that CBC is a powerful tool, but it's only right now in the time. So you need to look at previous ones if you can. Or if they didn't have a CBC, maybe they just have an H&H for a physical. That may be able to give you some information too to see if their hemoglobin and hematocrit were normal at that time. Reticulocyte count, again, those immature red blood cells. Maybe low, normal, slightly elevated, depending on when you're seeing this or what other contributing factors there are. LFTs are going to be an important function of this, right? Because that's telling you if the liver is actually functioning correctly. Again, look at those past ones. See, because LFTs is a snapshot in time. It may be showing you chronic disease, but what you're looking at is right now in the time. So you need to look at normal ones or other ones to see if there's a trend of this or if this is an acute process versus a chronic process. Why would we care about coax studies? Where's TPO made? Liver, and what's TPO do? Yeah, it regulates the platelets, right? So if somebody has chronic liver disease, you may start to see now some of these signs of bleeding disorders. That TPI on their legs, their arms, their abdomen. You may start to see that bleeding in their gums. They may be, when you do a procedure on them, like an IV, the nurse notes and tells you, hey, this patient's arm won't stop bleeding, right? Or hey, this isn't working correctly, or you're having to apply direct pressure for a lot longer because they have a low platelet count. And again, typically with liver disease, chronic liver disease, they're going to have contributing factors. They're not going to be the healthiest patients, so you're going to get those nutritional labs to see if there's any deficiencies in iron, B12, and folate. So just like chronic kidney disease, the most important thing you can do for this patient is manage and treat that underlying liver disease. Whether that's they're an alcoholic, you want somebody who's an alcoholic just to cold turkey quit?
No. Unless you want to give him a benzo ride.
Yeah, so I had a civil affairs officer in '97 who was well known across Fort Bragg because it's alcoholic. He got kicked out of the embassy on deployment. He got sent back home. Since he was a captain, everybody was just like, all right, we'll let him go do whatever he wants. He got kicked out of the embassy because he was a raging alcoholic on deployment. And then they continued stateside. And then they finally got a hold of him because he hadn't responded like in 2 weeks or a week to a cell phone call, to text or calls. And he's like, well, party's over, I need to quit drinking. So he just went cold turkey. The company commander came back, they escorted him to my office, and the guy was doing his DTs in front of me, like just shaking and like vomits in my trash can. And then the first sergeant's like, he just needs to man up and do, go drink eat a greasy meal and drink some water. And I was like, well, I don't think that's going to help his DTs right now. But he was a ticking time bomb. He ended up living in the barracks and had a 24/7 escort for about 6 months. But he couldn't put the bottle down, and then he got kicked out of the Army and drank himself to death. But I was trying to manage all this stuff on him because it's been going on for a while. Guy was non-compliant, kept going, getting sent to the ER, would get admitted. He got kicked out of rehab because all his medical concerns. He was a ticking time bomb. So you're going to have those patients like your panelists. So manage those contributing factors if you can, if you're getting those values. So if you find a deficiency in iron, B12, or folate, you need to track that down and treat appropriately. Avoidance of alcohol. What are some other lipotoxins? What's that? Acetaminophen, drugs, yeah, supplements. I had a medic in the '97, but before that he was my medic in the first cabin. I'll tell you who it was later, the guy that was '97. On deployment, he was from North Carolina, and he was taking supplements that he got in Iraq. They weren't American supplements, they were literally Iraqi supplements. He couldn't even read the bottle. And the guy told him like 1 scoop, and being from North Carolina country, he's like, well, I'll take 2. He kept doing that, and then we had to evacuate him to launch school because he had jaundice. He was going into acute liver failure in Iraq from these supplements. And when he got his ID card back, he got sent back to us after about a month. He was yeller like a banana, and that was from supplements. So look at what your guys are taking, what's available to them. Blood transfusions, if they are, again, that blood loss, underlying bleeding. If their liver is impacted, it's going to impact their platelets. It's going to impact their ability to control bleeding. So you may see that. Alcoholics, they also get those esophageal varices from vomiting, retching, right? And so a lot of times they'll die from that because of their, they'll bleed out. Or they may have chronic bleeding from those varices associated with alcohol. EPO therapy, considered in some cases, but again, maybe blunted due to other contributing factors, but there's something underlying. But those EPO therapies have their own risks. So this is something that hematology is usually going to make the decision, or nephrology in conjunction, to see if this is appropriate for this patient, if they benefit. Splenectomy, it happens sometimes, but there's a lot of risk factors associated with splenectomy, right? We have to be considerate of now they're at increased risk for infection. They're not going to be able to recycle their blood correctly. Other issues associated with that. All right, aplastic anemia. This is one of those scary ones because you're going to see pancytopenia associated with it. If you see pancytopenia, what's the first thing I want you to think?
Cancer.
Yeah, it's cancer until proven otherwise. You should have very scared if you ever get a patient, you draw a CBC and you see pancytopenia, because even if it's not cancer, most of the other things that cause it are very scary as well. So key characteristics is that decrease in all blood cell lines. What are those 3 blood cell lines that we're concerned about? RBCs, platelets, WBCs, and what cell line from the stem cell line do those come from? Myeloid, right? What's the other cell line? Lymphoid, and what comes out of lymphoids? T cells, B cells, natural killer cells, right? So clinical presentation, they're going to have anemia because it's pancytopenia, right? Then in addition to that, that easy bruising and bleeding, right? What's that associated with? What's causing that?
High platelets.
Those low platelets, right? Thrombocytopenia, and then recurrent infections. So what is that causing that? Leukopenia, right? So decreased white blood cells. They don't have a competent immune system that's able to do this. Just like down here below. So idiopathic is the most common, 50%. Then you have these other ones, right? I've had PANTS questions where Epstein-Barr virus is associated with it. Cytotoxic drugs and radiation. Not uncommon in oncology patients to have it, especially back in the day. We've gotten a lot better with our chemotherapies, being less aggressive and less toxic on the patient, and being more targeted, especially with biological agents that are coming out. Toxic chemicals, right? Solvents, insecticides. What are some insecticides that DoD used in the past? Pesticide, but yeah, it also can kill just about everything else. These anesthesia agents too, gold, right? I would say gold's less common. I don't see a lot of people inhaling gold, but maybe if you have a gold miner, maybe it is for this. But that hallmark finding is going to be decreased RBCs, decreased WBCs, platelets. Then you're going to do your blood smear, because that's kind of what follows CBC. For the most part, this is going to be normal. You're not going to see an underlying disease pattern. You're just going to see a decrease in all those on the blood smear. Required for diagnosis is bone marrow biopsy, hypocellular. So hypocellular, what's that telling you? It's telling you that there are less cells that are able to create blood cells, right? The cells that create RBCs, platelets, and white blood cells are just not there, so it's hypocellular. It's hypercellular, we're thinking like polycythemia vera, where everything is going up. It's kind of the opposite of aplastic anemia. We talked about with cancer being the biggest concern, right? So this is the differential diagnosis if you see pancytopenia. So MDS, cancer, leukemia, cancer, myelofibrosis, right? It's fibrosis of the bone marrow. There's a number of disorders that can cause that. Lymphoma, myeloma, carcinoma, cancers, megaloblastic anemia, which we talked about, right? And then you can also have these other disorders, hypersplenism or lupus, that can cause it. But see, pancytopenia, the first thing I want you to think is cancer until proven otherwise. You can eliminate the offending agent, right? If there's a medication, a heavy metal, some type of insecticide or something that's driving this train that's causing this, identify that as soon as possible and remove it. Talk with poison controls and other resources you guys can use. If you have somebody, they're available 24/7. Tell them like something like a drug or a product. They're the ones that have like the big MSDS, the safety data sheets and all the other stuff. They'll tell you exactly what labs, what treatment to initiate. Typically it's like ER physicians that have done a fellowship. Sometimes it's other physicians, but they're really helpful if you work in the ER for acute care setting. Immunosuppressive therapy, if there's that underlying etiology that's causing that. But the big thing they're going to get is bone marrow and stem cell transplantation. Typically, the stem cell transplants, the first people they're going to look at are relatives that are appropriate donors. Doesn't necessarily mean it has to be a family member, but in my experience, that's typically the first person they're going to look at is siblings, children, along those lines, or parents in some cases. Then supportive care, right? They have low platelets, so we need to address that. They may need platelet transfusion or additional medications. Anemia, blood transfusion, right? May just need RBCs, PRBCs, and then marrow stimulating agents, right? Those synthetic EPO medications or some other ones that may stimulate. Hemolytic anemias. right? So we talked about hemolysis is the premature destruction of RBCs. So if you think, you hear hemolytic anemia, I want you to think premature destruction of RBCs. You got to break this down into two classes, intrinsic or extrinsic, right? Intrinsic means the RBC itself, right? So whether it's fragile, whether it's misshapen, whether it has the wrong components, too many of one component or not enough, can cause that. Extrinsic is some type of external factor, not necessarily the RBC. So autoimmune, right? The body's attacking itself. Or mechanical, TTP, ITP, HUS. And then malaria is another one, right? So, anybody know about why sickle cell, like why the body adapted to sickle cell?
Malaria?
Yeah, it's a protective measure. So that's why you see it heavily in the African American population, is Africa, the body over thousands of years adapted and created these because they're less vulnerable to malaria. It doesn't mean they're not necessarily can get it, but even when they get malaria, it's typically less severe than people without sickle cell. So HSHE, right? Hereditary spherocytosis and ellipticocytosis. The name says it all, right? Spherical shape, spherocytosis, elliptical shape, lithocytosis, right? So they're either going to be shaped spherical or elliptical. But what that causes is whatever that RBC is misshapen, it's going to be more vulnerable because it is not doing its job correctly. It's more prone to hemolysis, to destruction. The body identifies it. You can also get splenic trapping, so that can cause splenomegaly where the RBCs are misshapen, so they can't pass through the splenic filtrations as easily. And so they're more prone to phagocytosis by those spleen macrophages. So with this, you're going to have some of the generic fatigue, pallors from that stuff, but now you're going to start to see jaundice, splenomegaly, because those RBCs can't pass those fenestrations. Gallstones, did you comment, Mills? So what would be like some signs and symptoms of gallstones? Right upper quadrant pain. What about when they eat? Fatty foods, right? What's that? The classic for gallstones, what do we think? Fat, female, 40, fertile, right? HE is typically a milder presentation versus HS, so that hemoelliptical is going to be less severe than the spherical. Spherical typically too is going to be more present in early childhood. It's going to be earlier on. HE, they may be asymptomatic, have some injury, illness that precipitates this, and then now they have this as an adult going on. You guys got to remember this, right? Aplastic crisis, parovirus B19. I've seen this on multiple of my pants. I saw this on Panry. I've seen this multiple times in my life. It's kind of there's other things that can cause aplastic crisis, but the classic is parovirus B19. Is that aplastic crisis presents similar like aplastic anemia, but it's an acute process and it usually lasts like 10 to 14 days. Once that body gets that parovirus B19 under control, that illness, typically the pancytopenia will start to improve, right? But parovirus B19. Then CBC is normocytic anemia, increased MCHC, that's the concentration. But you can see over here those shapes, right? What's going on with those other RBCs though too? A little hypochromic too, right? But then we see down here, elliptical shape, elongated, right? And then you're going to do your hemolysis testing, right? So this would be that case where you do that increased LDH, indirect bilirubin, increased reticulocyte, decreased haptoglobin, right? So this would be the indication for if you did that blood smear, you found these shapes, then you would do your hemolysis testing. Or if you have a high index suspicion ahead of time, you can go ahead and order that hemolysis testing with it. Rules out immune-mediated, the Coombs test. Blood smear is going to be a key for this because you're going to find those and see the shapes. And how you confirm it is osmotic fragility, right? So positive for HS, typically normal for HE. Again, HS is going to be more of a severe presentation in children. HE is going to be more adults, and it's going to be less severe or asymptomatic. Really depends on the severity of it, and if it's HS or HE. So that HE is less severe, so they may not need actual medications or treatment. They just may need it to be followed and managed that way. HS may be more aggressive, so folic acid supplementation is indicated. Transfusions really depends on the patient presentation and where they're at in their disease process, and if they have any comorbidities. Splenectomy, severe cases of HS, who would you send that to? What's that? So if you're thinking a patient needs a splenectomy, it's going to be a multidisciplinary team, right? So is the hematologist going to do the surgery? No, man, they're nerds. They don't do any of that stuff, right? So that's going to be general surgery, but general surgery is going to be consultation. You may consult with infectious disease as well, because now that patient is an increased risk for infection. ID may warrant there. If you haven't learned this yet in medicine, right? I got told this in day one in PA school. Share liability, right? What does that mean? If you have it, right? I would do this on deployments. I did stateside. I would call people and be like, hey, I have this patient, blah, blah, blah. What do I need to do? And they'd be like, well, you could do this, you could do that. And I'm like, how do I spell your name? And I make it very clear. And they're like, Smith. And I'm like, okay, how do I spell that? They're like, you know how to spell Smith? And I was like, I just want to make sure that I'm putting it correctly for my chart. Right? So don't go down with the ship, share liability. Get other people involved that are smarter than you, that have more training, and get their opinions and care on there, right? You don't have to be the last one with that patient. Prognosis, HS is typically good with treatment and managed close follow-up. HE varies, depends on the severity of it. Again, comorbidities, do they have liver disease, kidney disease? Did you find this late and now they're starting to get that splenomegaly and starting to get spleen damage? You don't have to know this for the test, I just put this on there. It's kind of an example. Post-splenectomy vaccine prophylaxis, right? They may be also recommended from ID that they stay on some type of antibiotic, especially in the initial thing. But you have a patient that has a splenectomy, right? Whether it's indicated for some underlying medical condition or they got in a car accident, they got blown up and the surgeons had to remove their spleen. You need to be managing those patients very closely, making sure that they're getting their vaccines, make sure that they are avoiding areas where they're more exposed to illness or infections. All right, lastly we're talking about is G6PD. So we all get screened for G6PD, right, in the DOD. It's part of your screening process when you go to MEPS. Specifically, we care about it because of medications. And the DOD, the #1 medication we care about is what? So it's anti-malarial meds, specifically Primaquine, right? Primaquine's kind of fallen out of favor for malaria prophylaxis, but there are other medications that can cause it, sulfa medications. So, X-linked genetic disorder, right? That makes the RBC more prone to oxidation. It doesn't have the protective enzyme on there. So, induced by exposure to chemicals, medications, infections, acidosis, and fava beans. The rest of your career, ever see fava beans? The only two things I ever think about in fava beans in my life is G6PD deficiency and what movie? Silence of the Lambs, fava beans. Where it does that thing, right? So I think about that. You ever see fava beans on the test? PANS, PANRE, phase 2 test, see fava beans, think G6PD deficiency. That's the only thing I can think of in medicine where you're going to see that. It's a weird misnomer or a kind of outlier. But more commonly, it's going to be medications for G6PD deficiency that we care about. It's going to create these Heme bodies. What that is when the RBC is oxidized, the hemoglobin becomes denatured and it creates these bodies, these remnants out there, which then leads to the spleen causing white cells, which we'll talk about here in a second. So Heme bodies and white cells are very unique to G6PD deficiency. But it's the most prevalent human enzyme deficiency in the world, right? So if you ever play trivia, it may be a trivia question. Not going to be a test question, but maybe a trivia question. And the #1 med that we always think about is Primaquine or sulfa medication. So why do you care is when you're doing that deep dive in a patient's chart, or they say, hey, I have G6PD. On one of your OSCEs the other day, I don't know if a lot of people saw it, but patient said I was G6PD deficient on one of the cases. In my group, there was 2 of them. We did that case twice, and neither of the students got it or picked up on that. The reason why that matters is that's going to dictate your prescription route, right? So a lot of times in Genesis and some of the medical systems, if you have that lab in there, what will happen is when you go to prescribe that medication, it will automatically trigger a warning and say, hey, this patient is known to have G6PD deficiency, or have you considered G6PD deficiency before prescribing this medication, right? So it may dictate what you're going to prescribe. Again, remember those fava beans. So this presentation is going to be pretty unique. Majority of the time, if there's no triggers, these patients are asymptomatic. They don't have any issues going on. Something's triggering this reaction that's doing that. Whether they just ate fava beans or they ever prescribed a medication, some underlying infection, something is triggering them to now be symptomatic. They're going to present, it's going to be an acute process. They're going to have jaundice, dark urine, extreme flank back pain. What else would I think with dark urine, extreme flank back pain? They said, hey, patient's like, I'm pissing blood, my back hurts. What's the first thing you think of the ER? Kidney stone, right? But typically kidney stones, you're not going to have jaundice. You're not going to have that impact on there, right? You're also going to have those kind of generic anemic symptoms of fatigue, dyspnea, tachycardia. The body's got to work harder. Laboratory findings, you're going to see these Heme bodies and bite cells, right? So Heme bodies we talked about, is that denaturing when the oxidation of the RBC, the hemoglobin becomes denatured and creates these kind of clumping up where the hemoglobin is not efficient anymore. Spleen doesn't like that, says we need to remove it. So the macrophages, it passes through there, it's going to take out this portion and bite it, and it looks like a bite out of there. That's what's causing your bite cells. You can see it in some other conditions, but typically when you hear Heme bodies and bite cells together, I want you to think G6PD deficiency, and then the trigger that caused that, right? So patients otherwise healthy, walk around, they've never had any issues with this. They get prescribed some medication, or they eat fava beans, then they have this presentation of jaundice, dark urine, extreme back pain, acute process very quickly, and then you get a CBC blood smear and you see these Heme bodies and bite cells, right? Heme bodies that denature hemoglobin, and then the spleen doesn't like that, so it tries to take the Heme body out, and it creates this bite cell. So on a blood smear, you're going to see probably both of them because it's an ongoing process. You're also going to order your hemolysis testing, and it's going to be just like the last one. You're going to see increase of LDH, increase of indirect bilirubin, increased reticulocyte count, and decreased hemoglobin. Confirmatory test for this one, right, is G6PD. So if you get that blood smear and pointing between Heme body and bite cells, you have an idea now, and how you're going to confirm that is that G6PD enzyme, and that's going to be decreased or not present. Screening, so again, we screen all of our U.S. military personnel. Right now, the U.S. Preventive Task Force doesn't have clear guidelines on screening personnel, but if you look through, or screening people in general, high risk, but if you look through some of the other guidelines from like AFP, or American College of Family Practitioners, or pediatrics, or hematology, they have some of their own guidelines on for screening personnel. Avoid those triggers, right? You know those medications, antimalarial, antibiotics are going to be the most common. There are other ones. If you are concerned with that, talk to your pharmacist and say, hey, another resource you guys are going to have at hospitals are clinical pharmacists, right? So that's not just the pharmacist handing out drugs, that's more the inpatient. Like if you go to the burn unit, they have their own pharmacist. A lot of trauma ICUs, some of the bigger ERs now are getting pharmacists that are embedded in the ER. What they're great with is a clinical pharmacist. You can consult the patient to them, or they'll evaluate all the drugs. And this becomes a lot more important when you have these patients on polypharmacology, right? They're on 20 different meds and you don't really know where to start. Like older patients, you're taking this, and there's no great reason. I'm looking through your medical records, but the next provider just kind of, here you go, we're going to add a second medication, but they didn't look at that first one. So now you get these patients with 20 different medications. You're not really sure where to go. Talk to that clinical pharmacist, and they'll kind of clear it up for you, give you some recommendations. Hey, you can DC this, this, this. These 3 medications aren't needed because they're being used for the side effects of these other 3 medications. So they've helped me out a lot in the past with just basically simplifying and giving me ideas of way to move forward when I get stuck with these patients, because you're going to get these polypharmacies where they had 10 PCMs back to back, or urgent care or ER start them on meds. Use those resources. Treat infections, hydration, prevent those nephrotoxic effects of the hemoglobin, supportive care if necessary, blood transfusion during crisis. So again, this is an acute process. It's going to present. They're typically going to get admitted to the hospital, and during that acute process, they may need a blood transfusion just to stabilize them, but typically they don't need long-term transfusions. Most of these events are self-limiting. We're going to do supportive care and DC those medications. All right, any questions about what we talked about? All right, we'll start back up on sickle cell tomorrow. This is fun, right? I told you. Hematology is like a blast, man. I'm having more fun with you guys, I promise you.